Good evening, everyone. Welcome. Let us know in the chat that you can hear and see me okay, because this is my first time hosting this event and I want to make sure everything goes smoothly with the tech. So feel free to pop into the comments, and please note that everything is anonymous. So I'll get into that. So this is my IVF Answers platform. And the European Fertility Society have come together and we've created this event to support and raise awareness and also to educate you. Anyone struggling with infertility, we know how hard it is. So this is why it's so important to discuss this topic. For myself personally, my name is Jessica Bourke, aka the Fertility Detective. I've been working in this field for about the last 20 years, and I'm joined this evening by Dr. Harry Karpouzis of Pelargos Clinic in Greece, who will be answering your questions regarding recurrent unsuccessful implantation. And of course, help me to make sense of this very frustrating situation that you might find yourself in. So just so you're aware, this event is being recorded. It is all anonymous. So the recording will be available to you afterwards the next day on my VF Answers and also on YouTube channel as well. So you'll be able to access it in different areas. We're going to start with just a brief overview of this evening's topic. And of course, at any point, you can chime in with your questions. So great, thank you for the thumbs up. You can hear us, that's wonderful. So just because there will be a lot of questions, I'm sure, to get through, but if you get the overview at the start, it should probably help you to think straight about what you'd like to discuss. So you can then type your questions into the chat like you did there, or into the specific questions box that we have for that. And then we'll be able to get started. So before we dive into this fascinating topic, I'm sure the viewers would love to know a little bit more about yourself, Dr. Harry, and everything that you do at Pelargos IVF, if you'd like to introduce yourself.
Well, hello to everybody. Another very interesting topic. First of all, thanks a lot, Jessica, for hosting this event. And I'm quite sure that it will be a very useful chat and very informative about everybody. I really like the fact that there will be a lot of questions, and we will try to help people understand a very difficult topic, which is very stressful as well for women that are in a situation of recurrent implantation failure. So, yeah.
Perfect. So let's start by defining it, because, I'm sure that's probably the first thing anyone would think of is, how do I know that I'm actually falling into the category of recurrent unsuccessful implantation? Like, how many times does this have to happen?
Yeah, I mean, definitions have changed many times. I mean, the most recent one, it is actually saying that we say that a woman is having recurrent implantation failures when we cannot achieve a clinical pregnancy after transfer of 4 at least good quality embryos in 3 at least transfers, fresh or frozen. I mean, this definition might change though, and it might put down a bit the number of transfers when we are talking about PGT-8 embryos, or when we are talking about egg donation. So in some of the most recent definitions, when we have 2 failures of chromosomically normal embryos or egg donation embryos, we can say that we have recurrent implantation failures. Of course, in women more than 40 years old that do not have good quality embryos, I mean, to have 2 or even 3 failures, it's something that it is not uncommon. Yeah.
Okay. So when you were saying there about has to be at least 4 embryos, that means individual separate transfers. So it's not the same as if there's a double embryo transfer, I presume.
No, I mean, it's in total the 4. Okay. According to the definition, we say that after transfer of 4 embryos, it can be 2 and 2, it can be 1, 2 and 1, for example. Okay. But when you transfer 4 good quality embryos in women less than 40 years old and you cannot achieve clinical pregnancy, you drop into the definition of recurrent implantation failures.
Okay. And then you also mentioned PGTA, so pre-implantation genetic testing for aneuploidy, just for anyone who isn't aware. So within that category, because you're testing an embryo and therefore the embryo is considered to be viable, does that mean there's any difference in how it's defined as recurrent implantation failure if you're having a euploid embryo transferred, let's say, into a 30-year-old versus transferred into a 45-year-old?
Not really, because when you have a euploid embryo, it means that it is not actually a viable, but a chromosomically normal embryo. Okay,
Yes.
we will talk later, and we will explain that
Mm,
this is not completely accurate as well, because it depends
mm,
on the definition of what we say chromosomically normal embryo. Because
sure.
in most of the laboratories, euploids, it means embryos that do have mosaicism, but the mosaicism is less than 20%. So they do have
Hmm.
some abnormal cells, but these are less than 20%. So even euploid embryos do have some abnormalities inside. I mean, if you transfer a euploid embryo in a woman that is 42, or if you transfer a euploid embryo in a woman that is 35, if they don't have any difference in other factors like endometrium or anything else, the chances should be equal. The
Mm,
only difference is in the extreme age limits, where we are talking about egg donation, for example, and
mhm.
situations like that, we have noticed that when you go close to the 50 or over 50 age group, the success rates are lower, even though we are talking about possibly chromosomically normal embryos or egg donation
Mhm.
embryos. You know?
That's really interesting. And in the case of the extremer end of the scale, why is it thought that is it to do with blood flow or immune factors? Why is it thought that there would be problems due
Yeah,
to an older woman?
it has to do many times because of the blood
Mm,
flow.
mm,
It has to do about the thickness of the endometrium. It has to do about the hypoestrogenic state that most probably these women have been for long, long time,
mm.
which might affect hormonically. And it has to do with uncertain factors as well. But we do
Mm.
notice a bit of, difference in the success rates, even with euploid embryos in these age groups.
Yeah, that's really interesting. And so, what about just as an overview for the categories? Because some questions are coming in that I'll get to. But, I think something that's very difficult for people in this situation is maybe to know where to begin and to understand, like almost like an umbrella view of what are the different areas that someone might want to explore who's dealing with this.
Okay. I mean, you split it. First of
Mhm,
all, it can be the embryo. Okay, you transfer embryos that you don't know the chromosomes of. And the
mhm,
most common factor is chromosomes. So the first factor is the embryo. And then the
mhm,
embryo can be the egg and the sperm or the combination of the two. So then you need to investigate about, is it a matter of quality? Is it a matter of quality of the egg? Is it a matter of quality of the sperm, or is it a combination of the two? And then in the
mhm,
sperm, there are hidden factors as well that are not obvious in a sperm analysis, like DNA fragmentation, like oxidation, for example. Then we have the endometrium. We can have
mhm,
endometriums that are not getting thicker, or endometriums that stay thin, or endometriums that do get thicker, but despite that, the embryo is not getting implanted. It can be autoimmune situations that can be disorders that have to do with the general health and an autoimmune disease, for example, but it can be
mhm,
localized factors as well inside the endometrium that play a very important factor, a very important role, sorry, because the implantation window is a very difficult thing to explain, and many different factors affect it, which are not completely comprehensive still.
mm,
Then you might have infections, you might have endometriosis, you might have issues with the implantation window. There are many factors, but generally it is
mm.
egg, sperm, embryo, endometrium, and general factors.
Absolutely. And so for someone who is, dealing with that, they've gone through multiple transfers that haven't worked out. Is there a starting point? Because often when I'm talking to people about testing, obviously you want to go with what's probably most cost effective first, maybe less invasive before more invasive, or what will give you the most useful information. So if someone presented in front of you, let's say, a 35-year-old has gone through 4 transfers that haven't worked out, what is usually going to be your starting point with that type of person?
My starting point would be the most common reason, which is the embryo. So my starting point would be to check first if the embryo is chromosomically normal or not. Because if you keep transferring an embryo that it is not chromosomically normal and then it fails again, you will not know the reason. And again, you will start investigating about more rare conditions without really knowing if the embryo is the problem. So the first thing is the PGTA, okay? And the first thing is to find out that you can achieve a chromosomically normal embryo and that you transfer a chromosomically normal embryo inside. And then if it fails again, you can start evaluating all other factors. Of course, okay, always when we have an unexplained failure of one embryo, only one embryo, and not recurrent implantation failures, we always suggest in our protocols to do a simple hysteroscopy as well, because in a hysteroscopy, you might find hidden reasons that you don't find in a straightforward, ultrasound, okay? And then it goes on and you go to the more rare conditions. But, the most important thing in situations like that is the consultation, is to explain to the person that is going through all that, to explain all the possible reasons, the costs of every, and the frequency. And then, there are people that want to say, listen, I have one remaining embryo, one remaining chromosomically normal embryo, and I want to check everything before I put it back. And to me, this is completely reasonable, yeah?
Absolutely. And just giving what you noted there, when I was talking about someone who's 35, let's say someone is under 35 and maybe the sperm has been tested and the DNA frag is looking okay, and there's nothing that would make you think that the woman's eggs would be at risk. Would it still be recommended to move to PGTA in that situation just because of the repeat unsuccessful attempts?
Listen, if we go to the definition that we talked before of recurrent implantation failures, and we are talking about 3 at least transfers that have failed with good quality embryos, then in a woman that is like 33 years old, then the frequency of having chromosome abnormalities might be rarer, might be more infrequent than other reasons, okay? So in a situation like that, obviously you will check about thrombophilias as well. Obviously you will do a hysteroscopy to find out if there is a septum that you are missing, if there is a bit of scar tissue, if there is a chronic endometritis or anything like that. And when you rule out these things that have maybe in comparison to chromosome abnormalities in this age group an increased frequency, then yes, I would do still PGTA in a woman that has recurrent implantation failures by definition, because you need to know what you put inside, because otherwise you will be again in the same problem.
Absolutely. And just for those who maybe aren't aware, so when you mentioned there about thrombophilia, you're referring to blood clotting factors and what would impact blood flow. And then you touch on endometritis, which, just in case anyone's aware, obviously that's different to endometriosis. We're talking about inflammation with the endometrium, and ruling out pathogenic factors. I'm sure you'd be looking at that. So yeah, that makes perfect sense, because certainly I've seen plenty in that situation, and it can be difficult making that decision, especially because, of course, investing, it is additional cost and time with doing genetic testing of embryos. And as we know from the research, there's kind of, sometimes it can be a bit controversial as to, whether it's as beneficial.
Jessica, you are right about that. But about this thing with the costing of the PGTA and, if you put everything in a balance, PGTA usually happens on day 5 embryos. And then we know that we cannot do a day 6 transfer because it has a reduced chances, so we freeze, okay? If you do the PGTA and you don't have a chromosomically normal embryo, especially in a situation of medical tourism, you don't have an embryo, you don't come back for a transfer, okay? Instead of coming back for a transfer, paying for an embryo transfer, paying the tickets for an embryo transfer, I think in the end, if you balance everything, the PGTA might, in the end, be more affordable than keep transferring embryos and missing things and doing embryo transfers and traveling to do these things again and again. Okay, so
true. I would agree with you completely. I was only playing devil's advocate from what I've seen, but that's exactly what I'd be saying to people, because I've seen people with 6 or 7 embryos, and it's just transfer after transfer after transfer, and they're trying to test things, and at the end they're back at square one again. And it does make a lot more sense. Particularly, actually, I'd be interested in this in terms of doing the PGTA testing. is there a number of embryos that you would want someone to have to really kind of have it be worth their while? Let's say they had gone through all their embryos because of recurrent unsuccessful implantation. They're kind of starting again. When they're going through the process, you're recommending PGTA. Would you recommend it if they only had 1 or 2 embryos, or would you prefer to see 3 or more?
You discuss it. You discuss it because, you know, PGTA actually, it used to be called PGS, okay? And it has the meaning of selection inside, okay? So when you have 1 embryo, you don't have anything to select. So, I mean, the important thing in a situation like that is to discuss it with the patient and say to her, okay, listen, you have 1 embryo, you can put it inside, go yourself through the, you know, the whole procedure of, you know, failing, taking medication, not knowing what is the reason of the failure, and don't pay for the PGTA, or you have an option of doing the PGTA and finding out if this is the problem or not. And it's a decision of every patient as well. We are here to explain to the patients what all the sides of their decision, okay, and the decision is theirs, okay. So in a situation like that, they can choose that I want to transfer it. Okay, you want to transfer it, but you need to know that it has an increased risk of miscarriage rather than a PGTA embryo. And if it fails, then you will not know what the problem is.
Well said. Informed consent. I absolutely agree. Giving people the information so that they can decide then what to do. That's brilliant. Thank you so much for that overview. I think I'm going to jump into the question box now because there's quite a few coming through. So I'm just going to see if I can display this question here so I can read it out to you. So hello, everyone. I've had a lot of blastocyst transfers, about 16. My goodness. I know it's because of my age and a lot of aneuploid blastocysts, but why do the embryos become blastocysts in the first place and not implant even briefly? So what are your thoughts on that one?
Okay. I mean, are the blastocysts, because it's not very clear, are the blastocysts, all of them PGTA, then all of them came back as aneuploid? If this is the case...
She just said a lot of aneuploid. She just said a lot of, but not all. Yeah.
So the thing is that the more eggs you retrieve, we have clear evidence nowadays that the more chances of achieving the 1 egg that will be the lucky one. To reach in the end day 5, it's a good step, but it doesn't mean that if we reach day 5 embryo, definitely this embryo will have the normal chromosomes inside. And depending on the age of the woman, I'm not sure how old did she say that she is, because I've lost the question.
Sorry, I can put it back in the display for anyone who still wants to see it if I can. Not sure if I can. It says, I have a lot of blastocyst transfers, 16. I know it's because of my age. So she doesn't actually say her age, but I'm guessing over 40. And a lot of aneuploid blastocysts. But why do they become blastocysts, but then they don't implant? I get what she's saying. I think she's saying, why do they even get to day 5 or 6 if they're then not even going to implant? Like, why would they even reach that stage of development?
Obviously, not all of the embryos that she has on day 1 have reached day 5. Some of them most probably have not reached that. But obviously, even though, I mean, her age must be more than 40, I mean, the more eggs that she gets, the more blastocysts she will have in the end, because the conversion rate as an average is about 50%. So most probably she has a lot of eggs, good sperm, fertilized, going to day 5. But then in the end, it's a matter of chromosomes. So, I mean, in the bibliography, it is said that in the age group, for example, 40 to 42, we need to have like about 15 to 20 eggs, and in some reports even 25, only to be lucky enough to have one of these eggs being chromosomically normal. And also keep in mind that the male factor, if the male factor is good, the male factor goes inside the embryo most probably after the day 3. So if we are talking about good sperm, this might help the embryo grow to day 5, but it doesn't mean that definitely will have the normal chromosomes as well, because this depends mainly on the age of the egg.
Yes, correct. Yeah, that's wonderful, because I think it's really important to emphasize that for people, because I think sometimes people aren't aware of the impact of the sperm from day 3 to day 5 of development, whereas the egg mitochondria driving it more from the starting point. So yeah, it's really good to have clarity on that. So the next one here, I'll just pop it up here. Hi, very simple one. Is a biochemical pregnancy classed as implantation failure? So very early pregnancy loss.
Yeah, usually by definition that we said, we are talking about clinical pregnancies, okay? And the biochemical pregnancy is not considered to be exactly in the definition. It doesn't count in the definition. Biochemical pregnancies, though, it's a category that it is also important and it gives us some information. So if a person keeps having biochemical pregnancies, and we are talking about 2-3 in a row biochemical pregnancies, this is a situation that needs to be investigated more as well. Yeah.
Yeah, no, definitely. And very tough because on that note, just with the recent ESHRA guidelines, that it is included as the definition for miscarriage, because I know that some people struggle with that and they don't know whether they should seek help or seek his support. But exactly as you were saying, if someone is experiencing repeated early pregnancy losses, they absolutely should investigate for sure. So the next one here, what advice would you give a patient that has had 3 egg retrievals, no embryo the first time, 2 embryos the second time, 1 fresh transfer, no pregnancy, 2nd frozen transfer ending in miscarriage, 1 embryo on the 3rd retrieval with no pregnancy? Would you try again, or would you move to egg donor?
Well, we are missing a very important information, which is the age. I don't know how old is.
I'll see if I'll check the comments, just if that person wants to maybe pop it in at the bottom about age. I'll see if they respond to that, because yeah, absolutely, that matters.
Yeah, and also I don't know the quality of the embryos or not. I mean, if we were transferring good quality embryos, and we are talking about a woman that's less than 40 years old, I would try it again, okay? Because we are talking about blastocysts, good quality blastocysts, so I would try to understand what is happening. By any means, this is a consented decision as well, again, because obviously if you compare it to the chances of egg donation, it will definitely be less. So you need to explain these things, that if you want to go with your best chances, go to egg donation. Okay, we're talking about 70%. Your chances in your age group with your own eggs will be lower. And if you have 2 or 3 failed transfers before, will be even lower than that, but it will not be 0. So you investigate it more thoroughly, because might be some issues that haven't been investigated, and you see if you can do something about it. But the woman needs to be realistic about her chances, yeah?
Yeah, and also it's a really big decision. Make sure, as any clinic should be, offering counselling if you are looking at moving to egg donation, because it's not something anybody would want to be doing casually. And you can post into the comments. I'll see if I can get back to that later on. Just there's lots of questions coming through. So this one here, can low LAD bloods, lymphocyte antibody detection bloods, cause implantation failure?
Yeah, I mean, it's a question that, by definition, yes, it could cause. It could cause also miscarriages. It needs
just
to
for
be,
anyone who isn't aware, just to explain a bit more about what they are, why it's important.
I mean, we are talking about immunological condition. Yes, we are talking about a condition that might be affecting the implantation, according to some studies. Might not be the only reason, of course, so other reasons need to be investigated, but the immunological status is a very important factor generally of recurrent implantation failures. It's a more rare one, but if we know that we have healthy embryos that are failing actually to achieve, we need to investigate about all these things. It's not the only immune condition as well. There are many other immune conditions that need to be investigated as well.
Yeah. Reproductive immunology is just enormous. There's so much to look at. It's a huge area. Yeah, because I don't think that person specified. They just said, can low LAD bloods cause implantation failure? I'm not sure if they actually tested them or not. So yeah, it's really just about the tolerance, because it's that one time when our bodies have to actually tolerate foreign DNA. So yeah, it's really quite incredible that any of us exist. So the next question here, let's see if I can display that one. Perfect. What is your advice to increase chances of IVF for a woman who is 42 and does want to do IVF with her own eggs? What would you recommend?
Well, first of all, advice before the IVF to prepare her. First of all, when we are talking about 42, the first advice is if she wants to go ahead with IVF with her own eggs, she needs to expedite things. Yeah. The second thing is to prepare well for the IVF with own eggs. There is no magic way of improving the quality of the eggs. We need to know that. There are many different treatments that have showed that they might have a beneficial effect, but nothing that is just a miraculous treatment. For example, vitamin D, coenzyme Q10, folic acid that any woman needs to take it. All these things have good evidence behind it. Melatonin,
melatonin, yeah.
To prepare herself, and generally a healthy lifestyle, and avoiding smoking, avoiding drinking, to prepare for the IVF. And then, of course, to do all the testing, to choose a personalized protocol. It's very important to personalize the protocols in IVF. A good laboratory, because IVF, it's the protocol that you will be put in to be personalized and according to your case. And second, the laboratory to be an advanced laboratory that will give you good results, and to try it, okay? And then every situation and every case is different, so the chances depend on what exactly is happening regarding her AMH, her antral follicular count, etc.
I think that's key. And especially so if someone at 42, what I'd always be saying to people is just to remind them, well, look, if you're having a regular cycle, if your hormones are looking on point, there's no signs of perimenopausal activity, because it isn't the case that just once you hit 40, you automatically go into perimenopause. There are many people who don't show signs of that until they're in their late 40s, from some of the people I've dealt with. But equally, there are some who are showing signs of perimenopause in their mid 30s. So it is exactly to say, it's individualized. They just have to get checked properly and make sure they can do everything to maximize things in their own situation. So a more general question here, an overview. Can you tell us, let me see if I can display it there. There we go. Can you tell us more about immune testing? Because of course it is such a vast topic. And I think maybe, yes, an overview of the different areas, the different tests that people might look at, because it causes a lot of confusion.
I will tell you what we do at Pelargos IVF. First of all, even immunological testing needs to be personalized, because I have noticed that in many clinics, it fails again, and then, might say, okay, take steroids, take inralipid, and you don't know why you are doing all these things. There are some reviews, very, very important reviews from a French immunologist called Lede, that we really try to apply in our practice, and they are talking about personalization of immunology. First of all, what happens in the blood, it's not always the same with what happens in the endometrium. It's other natural killer cells in the blood, other natural killer cells in the endometrium. Natural killer cells in the endometrium actually help in the implantation, and when they get more toxic for many different reasons, it's when they cause the problem. You might have a hypoactivity of the immune status in the endometrium. You might have a hyperactivity. You might have a mixed condition. And if you don't know what you have, then you might be giving steroids and causing the opposite effect. So what we are doing actually in situations like that is we prefer to check the endometrium with a biopsy. We prefer to check the endometrium after hormonal replacement treatment, because even hormones can change the immunological status inside the endometrium. If you do it in a random stage of a cycle, the immunological testing, it will be different than after estrogen and progesterone, because estrogen affects the immunology of the endometrium, progesterone affects the immunology of the endometrium. And then when we do a test, a biopsy, we go back and we see many different categories of cells inside the endometrium, like Th1 towards Th2, like interleukin 15, interleukin 18, cytotoxicity, CD54, many weird words that each of them has a different protocol. And when we are talking about hyperactivity, we can do steroids, we can do Placanil, for example, which is an amazing medication in some situations. We can do intralipids, I mean, we could do IVIG, but I mean, in Greece, unfortunately, we cannot do that.
Oh, it's not allowed in Greece,
It's very
IVIG.
difficult to find it, yeah. And
Interesting.
on the other hand, if we have hypoactivity, and we didn't know that we had hypoactivity and we were giving steroids or intralipid, the problem would become worse. So in situations like that, we need to balance the estrogen doses to give more progesterone, because progesterone affects the endometrium as well and the cytotoxicity over there. To do endometrial scratching sometimes. So everything that we do has a reason. So this is the testing, and it needs to be a biopsy inside the endometrium. Now, of course, we need to check about general immunological conditions as well, Hashimoto disease, Graves, and things like that, SLE. So we are talking about blood tests, and we are talking about biopsy inside the endometrium as well.
That's a wonderful answer. Such an important point, because I frequently see that problem with this generic approach. You know, it's immune, automatic steroids and intralipids. And I just really hope anyone watching really listens to what Dr. Harry just said there, because it has to be individualized. You need to always know the medical reason for why you're being given a certain prescription, rather than this just, we'll throw the A to Z of medications at it and hope for the best, because that's not a good plan. So thank you for clarifying that. That's brilliant. Next one here, this person notes, at the last transfer, my uterine lining was 14 millimeters. What height is too high, or what thickness is too much? Does the uterine lining also have to be 3-layered, so the trilaminar lining, during transfer?
Yeah. Listen, the problem is usually when we are talking about thin endometrium, okay? When we are talking about endometrium less than 7, ideally the endometrium needs to be more than 9. More than 8 is okay. Less than 8 reduces the chances. Less than 7 reduces the chances a lot. Now, trilaminar or not trilaminar? An endometrium is trilaminar. It means that it looks more healthy. So trilaminar is better, of course. If it is not trilaminar, you need to make sure that you don't have an ovulation as well. I mean, we always check the progesterone levels. Many units do not do it, but we have seen that many times the progesterone levels are important and you can miss things. So we personalize it as well in cases like that. Now, regarding the upper thickness, it's a difficult question, actually. I would say that if it is trilaminar and it is 14, the answer is that I would go ahead with it and I wouldn't think more about it. Okay, but when we are talking about very, very thick, we need to be sure that we are not missing a polyp, or we are not missing a polypoidal endometrium or anything else, so we can investigate it.
Yeah, causal factors for why it might be so thick. Yeah, that's absolutely true. Next one here, which is kind of following on the same topic. Just get this one to display, is, apologies. Same one, let me go back to that. Any advice regarding adenomyosis and recurrent implantation failures? So adenomyosis.
Yeah, adenomyosis is a very difficult condition. There is no treatment actually for adenomyosis. First of all, adenomyosis in a big percentage is also associated with endometriosis. So when we have adenomyosis, or we suspect, because many times we suspect it rather than we know that we definitely have it, we need to investigate thoroughly about endometriosis as well, because it is associated in many times.
Can you just quickly describe for people the difference between endometriosis and adenomyosis relative to location?
Yeah, endometriosis is when you have the lining of the womb being outside the lining of the womb, and it can be anywhere inside the tummy, it can be in the ovaries, it can be in the ligaments, it can be anywhere, and this is something that is causing painful periods usually, or pain in sex, or both of them. Okay, and this is endometriosis, and sometimes endometriosis is causing chocolate cysts as well. Adenomyosis is a thickened muscle of the womb. It's not a fibroid, it's not a discrete fibroid, but it looks very similar to fibroid tissue, and it is all over, it's diffuse, okay? Many times adenomyosis can be very close to the cavity, or sometimes it can even be inside the cavity, and you can have endometriotic spots inside the cavity, which are obvious in a hysteroscopy or in ultrasound. In cases like that, situation is difficult because there is no actual treatment, but sometimes down regulation before the embryo transfer with GnRH agonists might help, okay? And sometimes it's not the only reason. Now, about surgical treatment of adenomyosis for fertility reasons, it's a very, very conflicting issue. There is no clear answer. I mean, in situations that you don't have any other reason, it keeps failing and things like that. I mean, there are some surgical studies that say that you can remove adenomyotic tissue as well, but we are talking about a difficult surgery, a surgery with risks that we usually prefer not to go into this situation.
Yeah, it's not easy. I've seen some cases go to surrogacy in extreme situations. Yeah, it is a very tough one, unfortunately. So sorry to that person, what they're dealing with. Next one here. This is a bit of a longer one. So first transfer last year, 2 embryos, age 40, didn't take, had womb biopsy, all clear, Chicago bloods showing cytokine levels were double. So have been on the tacrolimus for 4 months, levels dropped to 30, tried another transfer again, good quality, 2 embryos, but they also didn't take. I have 2 really good quality left, but they're not genetically tested, and wondering what to do next. Have had another biopsy and got a call today to say there is something going on, and it will be discussed at a consultation in 2 weeks. I'm 42 in February. I have a 7-year-old boy, naturally conceived. 1 pregnancy ended in 2020 due to chromosomal issues. Sperm DNA frag was high, but got it under control before all of these embryos were created. So yeah, there's a lot going on there for that person.
There are a lot, but from what I hear, I mean, we are talking about non-chromosomically, we don't know, non-biopsied embryos, okay? And the truth is that now the embryos are already frozen. So, I mean, it's not an advice usually to defreeze the embryos, biopsy them, and then freeze them again, because obviously you can compromise them, and there is clear evidence that you can increase the miscarriage rate even if they are normal. So now that they are frozen, the only option is to explore all the other things that can cause a failure implantation, okay, to deal with the immunological status. But even if you deal with immunological status, if the chromosomes of these embryos are not correct, then again, it will not work. And we are talking about a woman more than 40, unfortunately. And usually, because they are the last embryos, you know, usually you put your best embryos first and then second. So the last embryos usually are a bit of worse quality than the first as well, but they do maintain some chances. So she can transfer them if she wants. I would, if it doesn't work again, I mean, before I go ahead with another IVF with own eggs, I mean, I would this time transfer embryos that I know. Generally, I'm a big fan of PGTA, especially in women more than 40. Okay, we use it a lot. And we do have very good success rates with PGTA embryos. So I always advise it in situations especially like that, and in women in this age group.
And with that in mind, given she has a 7-year-old son, 42 in February, so forward aging, so still 41, and with the 2 embryos, would it ever be then advisable to say, well, perhaps consider another retrieval where you could do the PGTA before moving to those embryos? Because obviously, you know, once you've gone through that, there's time, and then they might be older, and, you know, then they might have missed that window.
Of course you can.
Yeah.
I don't know the law in because, for example, in Greece, you might need to discard the embryos before you put the new ones. But of course,
we don't have that in Ireland, in the UK. Only I think in Spain you have to. If they're PGTA viable, like they were tested as chromosomally okay, then you have to proceed with whatever you've got. So yeah, thank you to that question. Okay, and the other one here is, at what time is it good to test for progesterone before and during embryo transfer? I'm worried that this could be a problem for me.
Okay, I mean, as far as it regards us, usually we test on the day that we will start the progesterone, and we test on the 3rd day of the progesterone as well, so that we can have the levels before. So in case the levels are lower, we add some injections so that we can bring them up. Usually, if at the time of the embryo transfer, the levels are okay, if you continue with the same doses of medication, they are maintained. Okay, so rarely we check after the embryo transfer as well. But in women that do have recurrent implantation failures, because sometimes it can be attributed to progesterone resistance as well. And there are some theories that say that women with endometriosis might have progesterone resistance as well. So you need to achieve higher levels of progesterone. We do check after the embryo transfer as well. What we do as a common practice is on the day of the start of the progesterone and 3 days later before the embryo transfer, so that we can increase the levels.
Which is amazing, because that is not standard protocol in Ireland. I'm sure you're aware. So to anyone who might be watching this, please know that you may need to actually really step up and request that is monitored for you, because it often isn't done as standard, unfortunately. So the next question here, is it worth freezing embryos and then doing PGTA? I was advised not to do it with my 2 embryos that I have in Prague. So I presume this is like a thaw to biopsy refreeze situation.
Yeah, I would say no as well. I mean, unless it is a very, a situation that the patient wants to do that for a reason, I wouldn't compromise embryos like that, because there is evidence that says that it actually doesn't affect the implantation rates, but it does increase the miscarriage rates. Okay, it's a different thing if you have a day 3 embryo and you can defreeze it, leave it to day 5 and biopsy it. But it's different to have a day 5 embryo and then defreeze it, biopsy it, and freeze it again. Okay.
Yeah, no, that's key. So someone else has a similar question. Okay, so this one is a longer one. Let me bring this one up. So I had 6 transfers, all blastocysts, and mostly 2 at most of the transfers from age 37 to 40. They were all AA grade or AB, but none implanted, bar 2. And there was a miscarriage, blighted ovum, and the other reached 6 weeks, and the heart rate slowed. I did have endometriosis, but all got to blastocyst stage day 5 or 6. The sperm analysis was okay, but never did the DNA fragmentation check.
Yeah.
So,
well, it's recurrent implantation failures. The way that it is described, it is by the definition a recurrent implantation failure. So it needs to be investigated. Okay, we need to investigate thrombophilia. We need to do a hysteroscopy and make sure that we are not ruling out anything. I would do the DNA fragmentation, because nowadays we do have some evidence that apart from antioxidants, techniques like Zymot or Max might help in selecting the sperm as well. And after all that, I would do PGTA as well the next time.
Yeah, that's really a tough journey. And just what you were saying about the Zymot and Max, they're just referring to sperm selection techniques, which you do usually with ICSI. So the next one here, does endometriosis play a role in miscarriage? I've had 1 chemical pregnancy and 1 miscarriage at 7 weeks. I'm 36 and I have 3 frozen embryos left. I'm assuming they're not genetically tested because it isn't specified here. So does endometriosis play a role in miscarriage?
Well, it is associated with miscarriages as well, but it is not the main thing that endometriosis is doing. So I wouldn't really attribute it, if they get implanted, as the main reason with endometriosis. Might be other reasons as well. But there are studies that have combined it as well with miscarriages, mainly through the progesterone resistance mechanism that I was telling you before. But I would check other reasons as well.
And for that individual, given she's 36 and she's 3 frozen left, I'm not sure she's had it before, but would you advise someone in that situation to maybe have a laparoscopy to just make sure the endo had been properly addressed before doing another FET, or not?
Not really. Unless we are talking about severe endometriosis, chocolate cysts, active disease, or anything like that. And unless it is associated with symptoms as well, like pain or anything like that, I wouldn't do it. You can downregulate. When we have endometriosis in the frozen protocols, we always downregulate. And if we are talking about a mild disease, it should be enough. I wouldn't put her into a situation of doing a laparoscopy.
Of having to do more invasive, absolutely. So the next one here. Failed implantation of 2 euploid embryos, downregulation with Prostat for 3 months, first transfer in February, and then letrozole and Prostat for the second transfer in September. Endometriosis stage 3 removed in May. Immune protocol for high blood natural killer cells for both transfers. Cytokines were okay. adenomyosis suspected on the ultrasound, but ruled out in a recent MRI. 8 transfers so far, 2 previous pregnancies, no live birth, unmedicated FET with untested embryos 2 years ago. 4 failed implantations with untested embryos and 2 fails with the euploid embryos. 40 now, or age 40 now, 3 euploids left. The next euploid transfer protocol, no downregulation and a medicated cycle, or try modified natural cycle. So I know there's a lot there for people to get a hold on, but obviously just talking about the ideal FET protocol.
Okay. Listen, well, difficult situation.
It's a lot.
She has done a lot of things that she should do. First of all, I don't know what exactly was the testing regarding the natural killer cells, etc. Blood tests, biopsy. I don't know if she has ever tested about implantation window as well. And chronic endometritis and things like that, because you need to know that endometriosis is associated with
bacterial
immunological status, but it is associated. Sorry if you hear, it's my dog that is.
It's okay.
It's also associated with chronic endometritis as well. So endometriosis and endometritis, even though they are different things, endometritis is an infection, endometriosis is what we described before, many times they are associated. So I would check about chronic infection as well. Antibiotics sometimes might be a reason. I would check about possible implantation window, even though the most recent, research and studies have not given a lot of credits on it. We do have cases that have done very well about it. I would ask her what exactly is the immunological status that she has done. And then regarding the protocol, given of the fact that we are talking endometriosis, adenomyosis, I would downregulate, okay? Because adenomyosis downregulation might help with that as well. But it's difficult. I mean, I need to know more things about the case to discuss about the protocol, what would be best, what happened before. I mean, I cannot give this answer just by that.
If most of those things had been done, let's say, and accounted for, because I think I know this individual, then I think the main concern is just because obviously with the down regulation, then they want the medicated cycle because you're obviously shutting things down. So it's hard for the ovaries. You need the extra help. But then the concern is because, with the research on doing medicated versus non-medicated FET, and there's some research now indicating that there can be better pregnancy outcomes if it's a non-medicated cycle. So I think that's why they're asking about the modified natural cycle,
exactly.
Which I believe was left as well.
And that's why I've told you that it's difficult to judge because on one hand here you have the adenomyosis endometriosis, on the other hand you have what you said. So I mean also I mean, I don't know if she has been investigated about the things that I've said before, and that if we do implantation window, then in a natural, semi-natural cycle, it's a bit more difficult to arrange all these things, to synchronize all these things, and so
timing.
I mean, difficult to give the answer. It needs to go
through. No, it is. It's a more in-depth one. But thank you for asking because it is important to cover. This one, nice and simple. You mentioned melatonin. What is the recommended dose and what does it do for egg quality?
Okay, listen, we usually give a smaller dose of melatonin in a supplement that includes other things inside. Melatonin has a main issue that you need to take it in the evening, actually, because it can cause sleepiness and.
Well, it's a sleep hormone, so yeah.
Sorry, what was the question exactly?
Just the dosage. So, what is the recommended dose, and what does it do for egg quality?
I mean, it works in an antioxidant way, like all the other antioxidants, actually, the melatonin, but it does have some reports that give quite good evidence behind it. Now, regarding the dose, I mean, I will need to check it up exactly what it is the recommended.
I believe it's around 1 to 3 milligrams.
I think so. Yeah. I think so. Yeah.
So for context, just in case anyone is unsure, like if you were trying to knock yourself back in after flying transatlantic, like I've seen with air hostess clients, that might be like 10 milligrams that someone might be taking, which, you know, is much, much higher dose. And provided it's taken in the evening, like right before bed, you're not going to drive in a car afterwards. It has a very high safety profile. I mean, it's not considered problematic, but of course, always check with your caregiver. Now, this one here asks, I'm 39. Had 3 transfers, 1 day 3 embryo, 2 embryos after PGTA, which didn't work out. Last transfer of only 1 embryo wasn't PGTA. It did lead to a positive result, but miscarriage at 9 weeks. The embryo was slow to grow. My husband has high DNA fragmentation, 20% according to the tunnel method. Normally it's under 12%, so maybe it's gone up. Could this be the reason for the bad quality embryo? Only grade 2 in the CZ. I'm not sure of the acronym there. Should we move to eggs donation? We don't want to have a sperm donor. What should we do? What is the reason for no implantation with the embryo after PGTA? I appreciate that's a lot there for you to absorb. But essentially,
we talked about all the possible reasons before. We said about endometrium, immunology, you know, other conditions. So all these things need to be investigated as well. I mean, 39 is not 42 or 43 or 44, and she did achieve some euploid embryos before. So I don't know if I would jump straight to egg donation and things like that. Now, regarding the sperm, I mean, yes, I mean, DNA fragmentation can play a role. It's a good thing to manage it either with sperm selection techniques or antioxidants, because with sperm, you can do some things to select the sperm. With the egg, you go with the eggs that you have usually. So the better sperm that you put inside, the more you improve the chromosomes possibly of the embryo and the conversion rate to day 5. So I mean, I wouldn't jump myself either to donor sperm. I'm not convinced that this is the main reason. 39 can give chromosome abnormalities. Did achieve a euploid embryo before. Maybe she can achieve another one. Check about all the other reasons and see. Okay. And as I said before, egg donation definitely would give better chances. But I mean, if a person doesn't want to jump to egg donation, has every right to try with her own eggs.
Yeah, I just completely agree with that. And this one here, what is the latest research on best things to do following a transfer, to rest or exercise or not? Are there any new studies or anything that can help implantation?
No, I mean, listen, to stay immobile or to rest doesn't have any evidence behind it. What we do advise, especially for people traveling from abroad, is in the next 3-4 days that the implantation happens or not happens, to take it a bit easy. Then mild exercising, not over exercising. You know, even reducing the stress, acupuncture, things like that. Healthy lifestyle, diet. There are special diets now that have to do with fertility. I mean, all these things help. I wouldn't stay in bed if this is the question. I would just avoid over activity in the next days.
Yeah, because there was a study in that, wasn't there, that said that this kind of lying prone on the couch, that there's no evidence, it might actually, in some cases, be counterproductive. And when you think about blood flow, it kind of makes sense. You know, none of us, anyone getting pregnant non-assisted isn't sitting still. So it should be pretty similar when you're transferring an embryo. And also, I suppose, the context of what someone was doing beforehand. Because, of course, someone who was used to doing CrossFit is a very different person to someone who wasn't exercising as much. So I think you're right. The individualization is really key here in terms of that advice. It wouldn't be something that could be just decided upon. So this person here writes this, an interesting one. I'm 38 and I had 6 good quality embryos. On the morning of transfer, they told me that they were infected. The lab results show that there was a vaginal infection associated, I beg your pardon, with QT bacteria linked to bacterial vaginosis. Could this cause the embryos to arrest in their development? My goodness, I'm so sorry to this person. So an infection in the embryos.
Where was the infection? I didn't understand. In
where? It simply said
laboratory. What?
It said the lab results showed that there was a vaginal infection, seemingly that the embryos themselves were infected. Seems odd.
I mean, I suppose we are talking about vaginal infection for her.
Yeah,
okay. Vaginal
presumably.
I mean, vaginosis can cause sometimes miscarriages, can cause things. It needs to be treated with probiotics or other things, but it doesn't have to do with the embryos. Okay, the embryos will not stop growing because of the vaginal.
I see. I think she was saying that this infection was discovered, bacterial vaginosis. So for those 6 embryos, was that what happened? Because it seems strange. She said on the morning of the transfer that they told her that they were infected. That's odd, isn't it?
I
Yeah,
think we are.
we might be misconstruing this, so apologies, but do let us know if you need to clarify. Incidentally, just because we're running tight on time, for those of you, if we can't get to your questions, please know that you can obviously follow up, I believe. Certainly you can get in contact with Dr. Harry and myself as well over Instagram. So, we don't leave anybody hanging because there's a lot of good questions here. This person writes, 35 years old, did first retrieval in January, got 9 embryos. We were unable to do PGTA because of public funding. 5 implantations have been unsuccessful and 2 pregnancy losses at a very early stage, 2 chemicals. If we need to start again, should another hysteroscopy be done if one hasn't been done in a few years? So 35 and had 9 embryos that were not PGTA.
Well, things in 2 years can change. Why not? An outpatient hysteroscopy wouldn't cause any issue. It can give you some information regarding endometritis, regarding other things. If it is possible to be done, I would repeat it.
Definitely. Yeah, it's a frustrating one because you see, we've only had the government funding in Ireland for the last year and a month. And as part of that funding, it doesn't allow for people to choose to do genetic testing, unfortunately.
Okay.
They can't choose to pay for that as an add-on, which is somewhat illogical, but that is the situation at the moment, unfortunately. So the next question here. If a 41-year-old is showing signs of perimenopause, such as hot flushes, weight gain on the belly, does this mean that the chances of a transfer working are slim with a frozen embryo?
Not really. I mean, if you do have the embryo, first of all, these hot flashes and everything, you need to make sure that it is not medicated derived. Okay, then you can do a hormonal profile and make sure that you are getting into perimenopause or not, because you can see that from FSH, estradiol, and things like that. And then if the embryo is already existing, even in women in menopause or perimenopause do have chances. You just need hormone replacement treatment to achieve the right thickness and to do the endometrial preparation.
Yeah, no, that makes perfect sense. So I know it's stressful for people, but it's very true. In many cases, it's a false picture because of medications and stuff that they've been on. So yeah, that's great advice. This one here, 4.5 years trying to conceive, now age 33. So this person was very young starting, have had 4 unsuccessful transfers and never been pregnant. Recently found out I have stage 2 endometriosis. Transfer post-laparoscopy unfortunately still failed. Interleukin-6 bloods are now raised to 6 and have been put on Plaquenil. Should I continue with the next transfer and use the same protocol with the addition of Plaquenil, or might it be another fail? All of them are untested embryos. So this person only 33. Yeah.
The interleukin-6 was found where? In the blood? In
Blood. It would be tested blood.
In
I can guess which doctor this person saw for that blood work. So
just,
yeah.
With that, she's on Plaquenil because of that.
I would imagine she probably had. I know the doctor. She probably had the repro flow or Chicago bloods done, I'd say, as well.
Okay.
Yeah.
Because only with the interleukin-6, there are. Plaquenil. It's not the only option, but by any means, yes, okay, you can keep trying with the Plaquenil, but it doesn't mean that your interleukin-6 it's the only reason of why it is not working. Okay,
True.
because many times we go to the more rare things, okay, and you don't know if it is other issues like the chromosomes, the embryo, the whatever.
For sure, but definitely, I mean, at this young age, like there's something going on. This person
Of
needs to
course,
keep
yeah.
pushing, and I'm so sorry to hear. So, okay, we're going to go for this. Will be the last question, guys. Okay, I'm really sorry that we can't get to them all, but we will definitely do our best to make up for that. So let me bring that one up. Okay, sorry. Now there we go. So I've had 9 miscarriages and all natural conception losses. Laparoscopy showed stage 3 endometriosis. The furthest I have got to is 9 weeks. I'm now 44 years old, was told recently that my only hope was egg donation as IVF is not an option at my age. Also, I have hypothyroidism but no living child. Any suggestions? God, that's really difficult. I'm so sorry for what you've been through.
Yes,
Yeah.
it is. And if we are talking about 9 miscarriages, it most probably means that she started quite younger with all this situation. I mean, things in the age of 44 are very, very difficult. Yeah,
Yeah.
are very difficult. Chances of success with own eggs to start with, we are talking about very low, less than 5%. I mean, egg donation definitely will take out the egg factor, which is the main thing right now. But because we're talking about 9 miscarriages that most probably started from a younger age as well, something else might be there as well. So, I mean, needs good investigation about everything because we're talking about recurrent miscarriages here in, consecutive. So it's a big issue. Thrombophilias, immunology, other conditions as well, because otherwise, even if she goes with egg donation, might fail again. Yeah.
Yeah, and I've seen that so many times with people. Please be mindful, everyone. While, of course, egg donation can be a very good option in some cases, it doesn't guarantee success. And exactly as you said, I mean, 9 miscarriages over presumably late 30s into early 40s, let's assume, as this person's 44. Yeah, it's unlikely that it's just the egg. There's got to be other stuff going on. I know you should mention hypothyroidism, so presumably make sure to rule out Hashimoto's as well, because I often see that being overlooked. But yeah, just so sorry to this individual. That's really difficult to go through all that. So unfortunately, guys, we can't get through. I can see I'm scrolling through. There are loads of amazing questions here. And my sincere apologies that we can't get through them all this evening. However, if you did find this helpful, okay, please know that there are numerous upcoming events that are being held on the My IVF Answers website, who are in association with the European Fertility Society. Also, please note that once this event has finished, you will be redirected to a short survey. Now, I know people don't like surveys, but it's in your favor, right? Because it's not just sharing your thoughts on how you felt this event went this evening, but anything you would like to see covered in the future. And that's obviously going to be to your benefit. So please do feel free to share your thoughts there. Thank you so much to Dr. Harry Karpouzis for your expertise, your helpful advice. I really hope that, I've no doubt actually that this will be of help to people. And may I just say, given I would be experiencing and seeing things from the side of, Irish and UK clientele quite a lot, it was really such a pleasure and so refreshing to hear everything that you were outlining, the level of due diligence that is done with the testing, with the progesterone screening. I only wish that I saw that across the board in all the clinics that I'm dealing with. So thank you so, so much. Is there any parting words that you'd have for people, or any information about your clinic that you'd like to share?
We are, first of all, thanks, and thank you for hosting all this. It's very helpful, and I really like these webinars. We are based in Athens. We are a fertility medical group. We in the year specializing with recurrent implantation failures and endometriosis. We deal a lot with IVF as well, and we like IVF because it's more challenging than egg donation. Laboratory, we collaborate with, it's amazing laboratory with artificial intelligence in the lab, with time-lapse machine for every single embryo. And we like personalizing everything. This is what we like to do so that we can try to increase the chances of success.
Yeah, which is what it's all about. At the end of the day, it's about giving the individualized approach and helping you to realize your dream family, which is wonderful to hear. So thank you for sharing that.
There is no 100% in IVF, and people need to know that, or whatever you do, and it needs a lot of patience and a lot of help with all these women struggling with for infertility, and especially recurrent implantation failures.
Yeah, very much so. As for myself, it was an absolute privilege to host this event, I have to say. And if you're looking for any evidence-based, non-biased support, feel free to contact me on Instagram. I'm at the Fertility Detective. That is my name. And obviously Jessica Bourke is who was speaking with you this evening. So that's it for now. I hope you all have a wonderful evening. And do bear in mind, like I said, that the recording of this event will be available afterwards, because I appreciate there was a lot of information to absorb. So thank you so much, everyone. And again, so sorry we couldn't get to all of your questions, but do know that you can contact us after the event. So thank you very much.